Hi again. Today we'll be studying ultrasound of pancreas. My name is Dr. Vibhu. I will be sharing the slides. Thank you. So the pancreas, it is a retroperitoneal organ and it develops from a large dorsal embryologic annulus and a small ventral annulus. The dorsal pancreatic annulus communicates by means of its central duct with the duodenum, and the ventral one communicates with the biliary tract. So there is a large dorsal and a small ventral. So these two fuse together during the embryological development. They rotate with the intestinal structure and ultimately fuse together so that the dorsal pancreas is located anterior and superior to the ventral pancreas. So as we see, the embryology is important because that's how the ducts develop. So this is the summary for development of pancreas. There are two outpouchings, ventral and the dorsal part. So the ventral one is the lower part of the head of pancreas, uncinate process. It forms the head and the uncinate process, whereas the dorsal part, it forms the upper part of head, neck and body tail. So this is how from the week 7 to 20 and up to the 15, the secretions come, the various other hormones are developing, the cells develop. And by the week 15, these are well there within the functioning of the pancreas starts. So this is just a table when the zygote forms ectoderm, endoderm, mesoderm, foregut, midgut, hindgut from the endoderm. Then the foregut forms lung, liver, gallbladder, and pancreas. So pancreas is basically a foregut structure, and then liver hepatoblast forms hepatocyte and biliary epithelium, whereas mesoderm only form the hepatic mesenchyme. So just to illustrate by the form of a diagram, you can see that the ventral and the dorsal pancreas, they keep rotating to around the second part of duodenum, and then they fuse together. So after the fusion, the ducts complete, and you can see the ventral pancreatic duct, which is localized above the dorsal duct. So there is a main duct and there is an accessory duct. So by the 8th week, the ducts are totally in place. If it doesn't happen, then there is in 15 to 20% people, the short ventral duct drains from the head of the pancreas through the major papilla and along a dorsal duct that drains the remainder of the pancreas through the minor papilla. This is called the pancreatic division. And in most people, the two ducts join and the minor papilla regresses so that the entire gland is drained from one duct that empties the major papilla. So this is the division. You can see the ventral and dorsal, they are totally separate. The main pancreatic duct and the ventral duct, they are two separate. This is called the pancreatic division. So this is the normal anatomy. The minor papilla of Vater and the major papilla of Vater, these are the openings. So in the pancreatic division, there is no communication between the two, whereas in the normal anatomy, both of them are communicating. And sometimes there is ansa pancreatica when the orientation changes. The minor comes below, the major goes up. So whenever you do an ultrasound guided puncture, you should always know about the pancreatic anatomy. Again, you can see that there is the ducts from the liver and gallbladder come to unite together with the pancreatic duct and forms a common hepatopancreatic ampulla. And this is the common bile duct, which is communicating with the ventral duct, and there is no communication between the two. Case of pancreatic division, whereas in a normal pancreas, there is the minor papilla is opening here, major papilla is where the hepatopancreatic ampulla is there, and the main pancreatic duct or the ducts are opening together. So this is the biliary tree. This is the normal anatomy. So you can see the accessory duct is above the main pancreatic duct, and this is opening into the hepatopancreatic ampulla, which is again opening into the second part of duodenum. So there are various cells are formed. These are the islet cells, which are the main This is just to demonstrate that how the foregut endoderm forms these various lines and cells. Yes, this is a ventral duct, this is a dorsal duct. There is rotation and then they fuse together. Okay. This is about the anatomy part, developmental anatomy. Okay. So you should also know the structures which are adjacent to the pancreas. So inferior to the pancreas are the superior and inferior mesenteric arteries, the SMA, superior mesenteric artery and vein. You can see here along the inferior wall, whereas the lateral wall shows pancreatic duodenal artery. This is a pancreatic or duodenal artery. Above it is the gastroduodenal artery. Here, then comes the splenic vein. Splenic vein is along the pancreatic body, and splenic artery is above it, up to the tail region. And you can see portal vein at the head region of pancreas. So why one should know about these vascular structures? Because when you do ultrasound, you will be able to see these vascular structures. So using these landmarks, you can identify the pancreas. So you can see the pancreas divided into mainly head of pancreas, body and tail. This is how it is divided. Then the same vascular structures. If you're not able to see the pancreas, then you should look for these structures. So because of its size, location, echogenicity, pancreas is one of the most difficult abdominal organ to be imaged. For this region, these vascular landmarks are useful in localization of pancreas. The head of the pancreas is located immediately anterior to the inferior vena cava. And when you tell the patient to be in left lateral decubitus or left posterior oblique position, the head of the pancreas may slide somewhat towards to the left of left, so that it is located over the aorta. Superior mesenteric vein is immediately adjacent to the posterior aspect of pancreatic neck and body to the medial aspect of pancreatic head. There is no retroperitoneal fat between the SMA or the portosplenic confluence and the pancreas. There is, however, a prominent ring of retroperitoneal fat that separates the superior mesenteric artery from the pancreas. So you can see the celiac trunk is here, from which the dorsal pancreatic artery comes. This is the splenic artery, which is running along the body of the pancreas. The gastroduodenal artery is along the head of the pancreas, and you can see the superior mesenteric artery along the inferior aspect of pancreas. So the body of pancreas is located anterior to the splenic vein, and portosplenic confluence tail is located below the splenic vein, and the trifurcation of the splenic artery is located just gastroduodenal artery arises from the common hepatic artery and travels inferiorly directly over the anterior lateral aspect of pancreatic head. So this is the pancreatic outline. This is how the ultrasound will look like, and you can see IVC, aorta. This is the splenic vein. Okay, this is the pancreas, this is the portal vein, this is the head, this is the anterior superior mesenteric artery, aorta, IVC, vertebral column. This is again head, body, tail. You can see the splenic artery. This is the superior mesenteric artery, aorta, IVC, left hepatic lobe, and splenic vein, which is inferior to the body of pancreas. So again, just images are just showing the same thing, that how to localize pancreas. This is again the normal variant anatomy. You can see that this is the body of pancreas. You can see the splenic vein going beneath it, IVC, aorta, also inferior to the. This is the gastroduodenal artery. This is the coronal view of the left upper quadrant, and it shows spleen, splenic vein, and pancreatic tail. Longitudinal view of pancreas at the level of superior mesenteric vein shows the body of pancreas anterior to the vein and uncinate process. Posterior to the vein. So pancreatic duct is seen segmentally in 85% of the patient. It is most commonly seen in the body where the wall and are perpendicular to the sound wave. And the portion of pancreatic duct that travels through the head is more difficult to visualize sonographically. However, it is occasionally seen medial to the distal common bile duct and should not be confused with the bile duct or with the low inserting cystic duct. So this is the transverse view of the pancreas. It shows pancreatic duct. You can see this is the pancreatic duct, and then also seen is the portosplenic confluence. Here is the portosplenic confluence, then IVC and gastroduodenal artery. You can see here. So right semiconal view of the pancreatic head shows distal common bile duct, and the small arrows are here showing the pancreatic duct. You can see the GB and gallbladder. So when the luminal diameter is very small, pancreatic duct may appear as a single bright line. The walls of the pancreatic duct should be smooth and parallel. 3 mm is the upper diameter for pancreatic ducts. In some patients, hypoechoic wall of the posterior surface of stomach rest on the anterior surface of pancreas can be confused with the pancreatic duct on transverse views, and this can be avoided by taking the image in multiple planes. And pseudocyst. Pseudocyst caused by posterior gastric wall, a transverse in a transverse view of epigastric shows what appears to be hypoechoic tubular structure running in the expected location of the main pancreatic duct. So you can see sometimes pseudopancreatic cyst can be seen along the pancreatic duct, and stomach is a good landmark for always seeing. Sometimes these stomach is not adequately distended, then you should follow the vascular landmarks. But with most of the cases, if you fill a stomach with water or patient is having drinking while doing the scan, you can see the pancreatic outline very clearly. So pancreatic echogenicity is variable depending on the amount of fatty replacement. Normal pancreas is equal to or more than echogenic than the normal liver. Pancreas can be hypo, iso or hyperechoic with respect to the spleen, and as the age increases, there can be fatty replacement within the pancreas. So this is the normal finding. Height should be less than 3, body 2.5, tail less than 2, pancreatic duct less than 3. Echogenicity should be more than liver, less than spleen. Echotexture should be homogeneous, and surface to be smooth to slightly nodular. This is the normal pancreatic head. You can see there is some fatty infiltration and normal hyperechoic appearance of the anterior head and hypoechoic appearance of the posterior pancreatic head. This is the head part, and then there are common bile duct here and aorta and the superior mesenteric vein. So this is the pancreatic head, uncinate process, pancreatic body. So then when we go to the pancreas scan with the patient in a fasting state, body of the pancreas is well seen from an anterior xiphoid approach in the left lobe of liver as an acoustic window aided by a deep inspiration. Visualization of body of pancreas is improved by the patient. Try to push abdomen out and make a beer belly. So it will help you to visualize the pancreas. And portion of pancreas, pancreatic head is usually seen at a right subcostal approach. Then, so the pancreas is scanned when the patient is in a fasting state. Body of the pancreas is well seen from anterior xiphoid approach using the left lobe of liver as an acoustic window aided with a deep inspiration. Portion of head of pancreas usually seen as a right subcostal approach, also viewed by positioning the patient in a left posterior oblique position. So this is the normal positioning of the pancreas. Here you can see the pancreas when this is the pancreatic scan plane. Here the probe should be positioned. And then you can see the pancreatic body, tail and head CBD, IVC, aorta, SMA, and these are the normal structures. So then you can make the probe sagittal, and then you will see the structure like this. You can see the head of pancreas here, and you can see the IVC along its length. Yes. So this is the normal pancreatic anatomy. We can see the pancreatic head body. This is the superior mesenteric artery, IVC, aorta, and left renal vein. This is in the sagittal plane. You can again see the body of pancreas. This is the liver. This is the aorta, superior mesenteric artery. Left renal vein is there. This is the coronal view. You can see the spleen, the tail of pancreas now. This is the splenic vein which is going. And when you do the longitudinal view, then you will see the superior mesenteric vein, body of pancreas. Then this is the superior. This is the pancreas which is above it, and this is the uncinate process of which is posterior to the vein. This is the transverse view of pancreas showing the pancreatic duct. There is a portosplenic confluence, IVC, common bile duct, and gastroduodenal artery, which is seen as an arrowhead here. This is the right semi-coronal view of pancreatic head. It shows a common bile duct and pancreatic duct, gallbladder. That's right. So various pathologies like so pancreatitis is the most common pathology. It is acute onset of abdominal pain. The enzymes will elevate like amylase and lipase. And characteristic finding on ultrasound, CT and MRI are there for such condition. So this is the healthy pancreas and this is the pancreatitis. So when the pancreas become inflamed, then we label it as pancreatitis. We can see pancreatic enlargement with reduced parenchymal echogenicity. This is the main hallmark for acute pancreatitis. Here you can see the pancreas with reduced echogenicity. This is the transverse view of pancreas, which is showing a small focal collection in the perivesicular space anterior to the splenic vein. This is a free fluid. You can see anterior to the pancreas. So this is the coronal view and the transverse view. Again, you can see that the right upper quadrant shows a small amount of fluid in the retroperitoneal space, and it is along the head of pancreas. This is the left kidney and spleen. You can again see fluid tracking along the margins. Case of pancreatitis. You can see a pancreas which shows a well-defined fluid collection anterior to the pancreatic tail here, and this is called a pseudocyst. So another complication for pancreatitis is the pseudocyst formation. This is the gallbladder. You remember gallstones sometimes cause such conditions of pseudocyst pancreatitis. Yeah. So this is in short brief about imaging of pancreas. And thank you.